Hey everybody, and welcome to our class on the Acute Grief Life Support. Today we're going to go over the slide sets on the Acute Grief Life Support and talk about the things that need to be implemented for Rockingham County. What are the objectives here? Well, we want to talk about why to consider the termination of on-scene resuscitation. We're going to compare the EMS to the ERs and how they're different. We're going to talk about the barriers to on-scene termination for resuscitation. We're going to discuss how to work with difficult families during cardiac arrest, and actually we're going to talk about discussions with families to have them present during the cardiac arrest situation. And we're going to talk about strategies to actually proceed to support the family during CPR, and not only during the CPR, but actually also the termination of the efforts. First thing, let's talk about this. We really don't have an industry bias about this. We don't have any kind of conflicts of interest or anything. We don't receive the monies or financial backings. We don't have a hospital behind us saying, well, we need to transport this hospital. They got to be seen in the ER. We don't have that. So, we have no financial conflicts of interest to actually change anything we're talking about today in this report when we talk about Acute Grief Life Support. EMS does make a difference. We do a great job with respiratory stress. We do a great job with STEMI. We do a great job with trauma patients. And we do a great job with CVAs. We actually own it. But with cardiac arrest, no, we're not doing a great job. The problem is we're failing to take care of our patients at the best possible levels. And a prime example here is when you look at the numbers of this. With the on-scene CPR or team-focused approach, or pit stop, whatever you want to call it, it has shown that on patients that do not receive pit stop, I've only got about a 5 to 8% chance of survival versus patients that are having the team-focused CPR, pit stop, or the team method. You have a rate, it can range, depending on the area, the location, and the equipment they carry, roughly the state level about 38% to the high 50s, even 60s. In other states doing this, just got back from Indianapolis, Indiana, they're having a 68% success rate with this. Wow. What a difference in the number. It's just obvious when it's that good how we cannot just try to do something different. So it makes sense. Would you do this to your patients on scene? Maybe your frequent flyers, but really a patient you care about. You see here, it's Seinfeld actually doing a pillow over top of George Costanza in the hospital. And it's a joke, but, realistically, are we doing that to our cardiac arrest patients because we're not willing to transport them? That's a very good question. Well, we do it every day across this nation. CPR on scene is the solution to fixing the problem with the low numbers for the success rate of CPR in the field. For years and years and years, we have been trying to just push through and move on and go away and just to get to the hospital fast as we can. You call, we haul. But now, the numbers are not lying. They're showing from all across this country that on-scene CPR works. Why do CPR on scene? Because at the ER versus EMS, let's be realistic about this. How many times have we transported the patient, and as soon as we get to the hospital, they're calling the codes? If the patient is not an overdose or hypothermia or related trauma, something recent that's related to the incident while they're in cardiac arrest, or if they're a pediatric, there's nothing the ER is going to do that we're not going to do. So realistically, we do the same thing. Does transporting CPR save lives? No, it doesn't. It makes it worse. common sense here. Why do we transport CPRs? What do y'all think? History? Tradition? Because it's just easier to transport them than sit and deal with the families? It's the fear. Fear's in there. We know that CPR and early defibrillation saves lives. It's not the fast ambulance ride. It's the thing of reducing the stress and the danger to all of us. You know, a lot of times, not being our administration, but other administrations, you have the lack of desire by administration. Why? The cost. We're going to be burning through extra equipment. The dispositions of the bodies. The crews are going to stay out of service even longer, and the lack of resources. All these things figured into usually why the administrators and medical directors are against it. However, with Rockingham County, our administration is behind it. Our medical director's behind it. Initially, when we heard about this, we were like, oh, I don't know. But when we start seeing the numbers, you can't implement. You cannot just not implement something like that. There is also lack of desire by the EMS crew. The fear of interacting with a family on scene. You know, before we launched this back in January the 2nd, I was very fearful of that. I was really worried about how the families were going to act because I just knew, I was like, oh, great, the first team focused CPR, the family's going to go ballistic and they're going to pull guns out and threaten my crews, and it's just going to be ruined. Well, actually, it happened completely in the other direction. We had a husband who passed away, and the wife came out and thanked the crew and the firemen for the great job they did. They were just blown away by everything we did to save him. That's huge. And it's repeated itself over and over and over again. We learned right quickly the fear of allowing the family to witness the resuscitation. It's not a fear. This should be raised. The wife came out, and numerous times the family member came out and held the hand of the person being resuscitated. The fear of responsibility, we've already got that responsibility. You've already responsible for that patient. Because what happens when you go to the hospital? Very quickly they call the codes because we've done everything they were going to do. They get to the hospital, we've done everything. The lack of protocols, that's not a problem for us. We have great protocol sets that were designed and developed just for the purpose of dealing with this team-focused CPR. So we have great success with that. Decreases the chance of survival significantly. Why is that? What causes that? Well, what causes that, honestly, is the best analogy I've ever heard of it is like making gravy. When you're making gravy on a pot and you're cooking it, it's really thin when you're stirring it on the pot when it's hot and you're moving it around. But when you turn that burner off and take the heat away from it and stop stirring it, it starts to thicken. It's just the way the blood works in the heart. When you allow the blood to sit there for a few minutes, it starts to congeal. You got to remember, 70% of the blood is water, or 70% of the body is water. 55% of the blood is plasma, which has got water in it. So it's not even white cells, red cells, or anything like that. It's just something that's going to thicken up. It's not the water or the plasma that starts thickening up. It's actually the red cells and all. The body starts to cool. The blood starts to thicken. It starts to congeal, if that's what you want to call it. It starts to turn into jello. So if we keep pausing more than 10 seconds and like we used to, and we stopped to intubate, and we stopped to move the patient, we stopped to put him in the back of the truck, we stopped because we just got knocked off our feet in the back of the truck doing CPR on the way to the hospital. It just makes sense that we're decreasing the chance of survival. Do you know that chest compressions in the back of an EMS unit going down the road is only done effectively 19% of the time? Think about that. That's 19% of the time. That is a significantly different number. So I want y'all to think about that for a minute. If I'm going to do chest compressions, as hard as we work on the CPR to only be good 19% of the time, that means 81% of the time the chest compressions we're doing are not working. Not working at all. Wow. That tells me quite a bit. So what is it about having family on the scene during the presence of CPR? Well, it's, they're there. They get to observe and feel what's going on. This is being discussed about for a long time. If y'all remember back in the major changes at ACLS back in 2003 and 2009, we started to see the difference in this. We started to see the difference in them bringing in the comment. It was a joke in ACLS back when they did it in 2003, and they talked about, well, have the family present when we do CPR. I mean, because everybody thought to themselves, really? That's crazy. That'll never happen. We've learned that it's working great. They get to see what we're doing. They understand. We've had great success with that. EMS has been doing this for 40 years. 70 to 90% of the percentage of the calls happen at the house. 70 to 90% over 40 years. That's a significant number. Looking at other services across the world, we're looking at, here's a study done in France with 15 EMS crews. It's randomized. The questions followed 90 days after the survivors are interviewed. Out of the 570 families that were enrolled, only 475 of them completed this documentation. 76% of the 475 actually witnessed intervention. 43% were the actual control group. One thing we did notice is that the PTSD was higher in that control group, but we also saw that we could see 3 validated total returns. We could see that 2,483 patients with CPR performed for 8 to 10 minutes. The survival at discharge was 6%. The return in the field was 36%. The survivability with ROSC was 17.2%, and without ROSC in the field, 0.07. Wow, wait a minute. What's that again? That's right. 17.2% of these patients with ROSC in the field actually survived. Without ROSC, 0.7. Let that just sink in for a minute there. That means less than 99% of the patients, greater than 99% of the patients. Wow, that is pretty significant. Here's a protocol that you could kind of look at to get an idea of termination here. Notice, termination of CPR. Are they greater than 17 years of age? Is the downtime greater than 20 minutes? Do you have an AED's initial rhythm, PEA, or systole? If yes, do not resuscitate. That is becoming huge now. Assess and address reversible causes. First responders, EMS, was the ALS intervention, BLS intervention? Do we have a ROSC? This is a protocol that's been set up for termination of CPR. Interactions with the family during the crisis. Nobody wants to deliver the bad news. Just ponder on that for a moment. Giving bad news in EMS is one of the toughest things we ever do. Dealing with families with this, because we've never really had a talk. We were paramedic class, went to paramedic school, went to EMT school. They talked about it, but nobody gave you a step process to deliver that bad news, to actually get that information out to them. So you really have to think about that for a minute when you think about it. Giving that information adversely affects his or her view of the future. Well, of course it would. If you don't deliver bad news right, it's going to make it even worse. But one thing is clear. Families want the truth. They don't want to be told, well, there's a very good chance they're going to make it. They want the truth. Being somebody who has gone through a loss of a child to cancer in her last week that she was alive, my 11-year-old daughter, I realized that because it hits home personally for me. Because when Lauren was in the hospital and she was sick, numbers that are still stuck in my mind today were truth told to me by physicians. They didn't sugarcoat it. They said gravely sick. the chances of her making it in the next 48 hours are less than 20%. So, these things you remember, and to be given the truth, it helps you to get through the grieving process. It starts that grieving process. It tells you on what's more likely going to happen next. It is unethical to withhold clinical information, to delay delivering the bad news that affects the future adjustments. It's just not right to do. Think about this. How many times in the past have we ever gone out to a house and run a code and actually said the word dead? Very rarely. Very, very rarely. If you did that when I first became a paramedic in the early 90s, they shunned you. You got a talking to by the senior medic when you got back to the base. We don't say things like that. Now we embrace those things. We actually embrace that with the family. We reach out to interact with the family and let them know what's going on so they know the truth. We embrace that. So what is the goals when we deliver bad news? And of course this comes from the Spike studies, a 6-step protocol to deliver bad news. It was actually an oncologist group that come up with this. And it works very effectively. Why? Because oncologists with cancer, it is very rough. And they have to deliver the bad news. Gather the information from the family. Provide the information to the family. Support the family by reducing the emotional impact and isolation by being there for them, because they're going to ask questions. They're going to want to know what, and don't feel upset when they start questioning you or querying you on what you're doing and how you're treating your patient. Form a treatment plan, the same of a new patient with the family. And for cardiac arrest situations, tell them, okay, we've tried this and this for the last 10 minutes, but we still got a few things we're going to try. But be honest, this is not looking good. They're still dead. They don't have a pulse, and they're not breathing. We're doing that for them. And that cannot continue forever. The strategies to help us both are the best methods here. We are uncomfortable giving bad news because of the avoid the situation information. I mean, come on. To get a paramedic or anybody EMS to go to the funeral home is like an act of God. People don't want to do that because it deals with the inevitable. We see death in the field. If you've worked here more than 5 years, I guarantee you've got a touch of some type of PTSD or something like that, because we see death. See a lot of it. And it's something when you really don't want to deal with on the finality of it, because we are short-term memory medics. We get these patients and we only have to put them in our short-term memory. They don't have to stay there forever because they're with us so few of the time. But on the codes, it takes longer. We do not have a standardized way or protocols to help us. Disclosing bad news should be a stepwise. Step 1 through step 6. Delivering it to them every time. So every patient gets the same universal, informed approach to delivering bad news. So what is our strategy to exit to help? What is the strategies we're going to do? Or what exists? Unfortunately, not a great deal in EMS. We have medical literature, we have pediatric literature, oncology literature, palliative care literature, hospice literature, military training, and police training, but we do not have any training that's given to us in a paramedic class that helps us, or an EMT class, that helps us deliver this bad news to the family. We've never been taught how to handle this. What is the difference in our situation? Bad news has already happened. We're right in the middle of it. We are just right there. It's just like, if you could coin a phrase, it's the worst case scenario to give bad news, because we're there with the bad news. They're not away like a state trooper delivering the bad news of a death of a child or a death of a family member. We're there and they're right beside us. Spikes is an algorithm that people use. It's used by oncologists. It's setting up for the interaction, the perception of the family, the innovation to hear the news, the knowledge to receive and given, the emotional address, and strategy and summary. The joke is spike me, and that's what you do with patients and families. It's just one way of handling it. You mainly want to rehearse and prepare yourself. You don't want to go in there cold turkey and speak to these people without thinking about it for a second. You want to get privacy in this situation. You involve the significant others. If you have clergy there, that would be great. If you have a friend or family, let them come in too. Sit down with them to give them the news. Just don't go in there and stand there like, okay, I got to go back. But if you're the only person, you're the lead medic on the code, and you've got to go back to do the treatment algorithm, it's understandable you go in there and say, I'm just going to be a second, but I just want to tell you, things like that. Make connection with them. Make eye contact. Introduce yourself. And also outline a time frame. Discuss how long this is going to take. The P stands for perception. Gather the information pertaining to the situation. Assess the family and what they know, and assess the accuracy of the family's perception of the situation. The I stands for invitation to hear the news. Look for clues during discussions to open the bad top with a news topic. Realistically, this is great for oncology, but it's a little bit different for us in the field. The K stands for knowledge. Warn the family the bad news is coming. Give them a level of so the family can actually comprehend it, but make sure that you keep it on a level that they can understand. Don't use medical jargon. Don't say, well, the patient was in asystole, and we've given heparin and atropine and Q this, and we're doing this, and we're going to do some transcutaneous pacing. Put it simply. Say, look, their heart's not beating. On the monitor right now, it's showing no electrical activity. We're going to give some more medicine to try to kickstart their heart. We're going to use electrical therapy if we can get something on the monitor that we can shock. If not, we're actually going to use electrical therapy to make the heart beat. It might respond, it might not. But right now it looks very grave, and it doesn't look good. The E stands for emotional address. Responding to their family's emotions. You're going to have silence, disbelief, crying, denial, anger, shock, isolation, and even explosive. Observe the emotional response. Identify the emotion and give the family a period to express their feelings. It's not bad for those to feel things. Now, of course, it's not good for them to sit off, haul off and punch the wall, but it's not bad for them to go through these steps. It's an emotional step. Now, let's deliver a plan. We gave them the bad news. We gave them time to get over it. Let's give them a plan. Because when we give them a plan, it helps them out. So you're asking yourself, I've got a protocol. That's not what it means. It means giving the family a plan. You go in there and saying you're 10 minutes into the code and you're saying, look, we've been coding this person now for 10 minutes. We're doing mechanical chest compressions to make their heart beat. We're using a bag valve mask to make them breathe. We're actually putting air in their lungs. But they're still dead. They don't have a pulse and they're not responding. Our game plan is for the next 20 minutes, we're going to try different things to make this work. We're going to give medications to stimulate or to make the heart want to beat. We're going to use electrical therapy to start it back up or to become the heartbeat. But we don't know how the heart muscle is going to respond. Explaining a strategy to the family of what you're doing next. And say, I'll be back in the next 5 to 10 minutes to come talk to you again to give you an update. Grieving comes from, it's an algorithm that people use. Gather the family, resources, call what you needed, identify yourself, the family's knowledge, educate about the situation, verify the information with the patient. The space for the pause between the grieving is actual, you can see the grieve with the underscore. It's actually giving them time. Now, inquiries for questions needed. The nuts and bolts are the legal paperwork and things like that. And give the family contact information of local resources for grieving. One thing we're doing just to mimic Stokes County EMS, we're actually come up with our own flyer that we're going to be putting out to all the units and probably sending out electronically to the fire departments so they can actually have this information available to them to provide to the families. Because nothing's better than having a piece of paper with maybe some steps on it, things what to do next. The G for grieving stands for gather and give. The R stands for resources. The I stands for identify. The E stands for educate. The V stands for verify the family's name, verify the situation, and use the word dead. That's right. I'm sorry. We're dead. The space allows space. Allow them to process and react. Allow silence, and it's okay to touch. The The I is for inquire. Inquire if the family has any questions. Inquire if there's anything you can do for them. One thing I always do is say, is there anybody else we can call? The nuts and bolts of it. Talk about the legal aspects of death. Talk about the funeral service premises. Some of this stuff you can hold off. The end won't be until you're maybe 25 to 30 minutes into the code and you're getting ready to call it because you've got no responses. It might be time to start saying, do you have a funeral home of preference? But, wait to near the very end to do that. Don't preempt in the first 5 minutes saying, you got a funeral home? I mean, how horrible is that? Talk about personal belonging. Viewing the body, and organ donation. That's a very good topic. The G stands for give. Give the family your name and contact information. Give opportunity to ask questions. Make sure the family has support and give them information on local resources. That's what we developed this flyer for. We've actually spoke with hospice, and the chaplains from hospice have stepped up to the plate where they are going to allow to do some grieving sessions for them. We're very excited about that. So let's get into the 4-phase approach of the actual Acute Grief Life Support. Let's break that down even more. Now, of course, what does AGLS stand for? Acute, to assemble, ask, and advise. Grief, to get and give information. Life, let them process, react, and ask questions. And support, situation updates, summarize the events, and secure information and secure the scene. The phases of care of interactions. Treat the family during the resuscitation. There are 4 phases to that. Our first phase is your 5 to 10 minute phase. Assemble, gather, and explain. Use the word dead. That's very important, guys, if I can't relay that enough. Tell the family, I am sorry, but your loved one has died. However, we've got a few minutes that we can try to do everything we can. And our best chances of getting a heartbeat back is right now doing everything we can right here and not moving it. We want you to understand that. At phase 2, which is 10 to 15 minutes, give an update. Tell them after you leave at 10 minutes or 5 minutes, say you'll be back in 5 minutes. Notice it's in 5-minute increments to near the very final phase. Phase 3, do an update, emphasize dead and the low likelihood of survival. And phase 4 is closing out the resuscitation effort. This is when you're starting to say, I'm very sorry. We've been trying to do this now for 25 minutes. Still no pulse. They're still not breathing. They're still dead. We're going to try for about another 5 minutes here. But after that, we're going to terminate our efforts. I think it's time we talk about the likelihood that they're not going to recover because they are dead right now. We're not going to get a pulse back. Start talking about the terminal. And of course, the finale of phase 4 is closing out the resuscitation efforts of telling them, I'm sorry. Your loved one has passed away. There's nothing else we can do. I'm very sorry for your loss. Is there anyone else we can call? Now, this is what we're going to have to do. We're going to have to contact the medical doctor. If they agree to sign the death certificate, then we will take the patient and turn them over to the funeral home of your preference. Those are some of the steps. Let's break that down in a case study using AGLS. You arrive on the scene with a 50-year-old male. He's mowing the yard. He comes inside and complains of weakness. The wife actually sees him collapse from a kitchen chair. She calls 911 and gives bystander CPR. The first responders arrive on scene with an AED and a blind insertion airway device, or a King airway. Team-focused CPR, high-quality resuscitation is ongoing. ALS arrives. They do an IO. PEAs noted. They give 1 milligram of epi 1 to 10,000. In the first phase of it, phase 1, we assemble the family and others in a quiet, separate space from the resuscitation. We have everyone sit down and ask if you may sit and use empathy or empathetic lucid empathy posture. Show that you really relate to them. I usually take a knee, especially with my height. I'm 6'6", so I take a knee and get right next to the matriarch of the family and just say, "I am so sorry." Allow for privacy. Ask their names, the relationship, and give yours. Ask if you need to get additional resources there. Ask if, and by additional resources, we mean like a pastor, a family member, a daughter, a brother, whatever. Ask what we can do for the same situation and advise them. Phase 1, get the information pertaining to the situation. Get the sense of the understanding of the situation. Give the information to the family. Give the bad news. Mr. Smith's heart is not beating. He's not breathing, which means he died suddenly. Give the family reassurance that you're going to keep them updated and allow them, if they want to, remain with their loved ones. If not, they want to come in and see them, give them that chance too. Give someone to stay with them during their resuscitation effort. The L stands for let them have time to process, let them ask questions, let them have silence to process the information themselves. Let them witness the resuscitation efforts if they choose. If they don't choose, that's understandable. Situations, update every 5 to 10 minutes, summarize and give current events, and secure ongoing family support. So in summary, this is what we're looking at. Resuscitation priority is top priority, but the family is equal to that. So don't forget the family is our second patient. I understand Mr. Smith was doing well today before moving to his yard. He felt unusually weak, and then he collapsed. You called 911, and thank you for starting CPR. That's very important, but unfortunately I have some bad news to give you. While we are not exactly sure what happened to Mr. Smith, his heart is not beating, and he's not breathing, which means he has died suddenly. We are compressing his chest to pump his heart and place the breathing tube to give him oxygen. We are using a defibrillator and medications in order to try to restart his heart. We're doing everything for Mr. Smith that we can be done right now here in your home. In fact, the doctors do not want us to move him because every time we stop CPR, it decreases his chance of survival. When somebody dies suddenly, the chances of them surviving is very low. It's less than 8%. So everything is done for them. We're giving them every chance for survival right now, but unfortunately his chances of survival are low. I know this is a lot to tell you right now. Do you understand what's happened? Give it a pause. Do you have any questions? These things are all important to explain to the family. Very important. Phase 2. We're 10 to 15 minutes into this code. We've not sent any response. Again, we assemble the family. We ask and advise them what's going on. We get the sense of their understanding of the situation. We give information. We give bad news. Unfortunately, Mr. Smith is not responding to our efforts. His heart is not beating, and he's not breathing. We will continue to work hard to restart his heart, but with each passing minute, the chance of survival becomes less. But we do reassure the family we're still working, and we do get somebody to stay with them. We let them have time to process the information. We let them ask questions and answer them honestly. We let them have silence. Silence is okay, but for us it does feel awkward. We let them witness the resuscitation if they choose. We give them situational updates every 5 to 10 minutes. We summarize the situation and secure the ongoing family support. Phase 2. The top priority for us is resuscitation is the top priority, but the family is still equal. After 10 to 15 minutes, you reassemble into a private area. Despite our efforts, Mr. Smith is not responding to our treatment. His heart is not beating, and he is not breathing. He has been down for 10 or 15 minutes, whatever time has expired, since he collapsed. With every passing minute, his chance of survival drops less. We are continuing to compress his heart, breathing for him, giving him medications and shocking his heart, but he's not responding. Once a person has no heartbeat for 30 minutes, the chance of survival has reached zero. Again, I know this is a difficult time for you. Do you have any questions? I will return in 5 to 10 minutes with an update, if that's okay. Then we approach phase 3. We're 15 to 20 minutes into it. We examine the family again. We allow them to ask questions, and we advise them what's going on. We get a sense of what's going on. We get the information. We give the bad news. We give the family reassurance of what will keep them updated, and we give someone to stay with them during the resuscitation efforts. We let them have time to process this information. We let them ask the questions, and we answer them honestly. We let them have silence, and we let them witness resuscitation if they choose. We do situational updates every 5 to 10 minutes. We summarize the situation, and we secure ongoing family support. Again, resuscitation in phase 3 is our top priority, but the family is equal. After 15 to 20 minutes, you reascend the family into a private area. Unfortunately, I have bad news. Mr. Smith is not responding to our treatment. We will continue to provide compressions to pump his heart, and oxygen as well, and medications to start his heart, but he's not responding. With each passing minute, his chance of survival grows less and less. After 30 minutes of no heartbeat, the chances of the survival are zero. I am very sorry. Our entire team is working very hard to save your husband, but he's not responding. Again, I know this is a very difficult time. Our team agrees we have attempted everything medically possible to resuscitate Mr. Smith, but he's just not responding. Once we reach the 30-minute, or you can say 30-minute mark, or however you want to explain it, once we reach 30 minutes, his chance of survival is essentially zero, and we will need to think about stopping our efforts. Do you have any questions? Give it a pause. Is there anything we can do for you? Give it a pause. Is there anyone else you would like us to call? Showing them that you care in phase 3 is the beginning of developing an excellent patient care rapport with the family. That's very important. Showing a caring heart goes a long way. Phase 4. Assemble the family again. Ask for additional resources for the family if they need it. Ask the family what you can do for them, and advise them the situation at this point. Because what they're hearing right now, they're not hearing you ask. They want an update. Over the last 3 stages, we have set the tone for this. We're going to give the bad news now. We're going to give the resuscitation, the family reassurance that we will update them, and we will give them the information they need. We'll let them have time to process it, let them time to have to ask questions, let them have the silence, or if they want to witness the resuscitation, we allow them to do that. We summarize the situation, we secure the ongoing support, and now we start thinking about and securing the scene for a medical examination. We secure any debris, we clean up the resuscitation area, and we move furniture. Or any furniture we've moved, we need to correct that. If possible, we place the deceased in a bed or sofa. That's after you have secured the medical examiner or the physician's signature for you doing this. If it's a medical examiner, you take him to the hospital. If it is a physician that's signed for it, then we can do these following steps. You would raise the head slightly, ask the family if they'd like to see it. Leave a handout so the family can touch it. Allow the family to spend time with their loved one. Treat the body with the utmost respect. Phase 4, this is the big change. The family now is our top priority. This is what we're dealing with the most. After 20 to 30 minutes, you're reassembling in the family area. You allow time with the family to process and explain the variety of the reactions, from silence to rage. Rarely rage is seen, but physical violence directed to you, just be prepared. If they go off on you, be prepared. You and your partner are the most important people in that scene, so be prepared. Ask them, is there anything you can do for them? Allow the family to lead the interaction. Always refer to the deceased by name, Mr. Smith. Explain to them the process of following death, your local protocols, the death certificate, signing the funeral arrangements, or medical examiner case. Notify organ donation organizations. We're going to help them make arrangements for the family if possible, and realistically. Release unnecessary responders from the scene. Let the firemen go. Let the first responders go. Keep somebody with the family until the deceased is removed. We've been using supervisors to stay on scene if it's been a long scene time. We have developed a local resource brochure with our agency name on it for the families. Some things not to do, not to say. One thing I want to go back to, and I want to say it, I want to read the bad news out here because I didn't highlight it like I did before. And that is, unfortunately, Mr. Smith is not responding to our efforts. His heart is not beating, and he's not breathing. We're now close to the 30 minutes mark. His chance of survival is 0. Our team agrees we have done everything possible, and we agree we must consider stopping our effort. We would like your permission to stop the resuscitation. I am very sorry, but Mr. Smith has died. And be blunt, right now we're stopping the resuscitation. Mr. Smith has died. Let them know what's going on. Give the family reassurance and talk to them. Things we don't ever want to say to people. Things not to say. Do not get into a religious discussion. That's not what we're here about. Don't go in there and say things that are incorrect. Don't go and say, we've lost him. He's gone to the Lord. God must have a plan. Expired. I'm sorry they passed away. The caption here is funny. It says, I just found the expiration date on your scalp. You want to know what it says? Or be surprised? Be understanding of what you're delivering. It's devastating news. Well, not to say, he's in a better place. I know how you feel. It's happened to me. He had a good life. At least he's not suffering. It was the best. Well, at least you have 2 children. Well, nobody lives forever. You're young. I'm sure you'll find another spouse. We've developed a brochure for the family with information on that brochure. I'll let y'all look that over. So in summary, remain professional and compassionate at all times. Please choose your word wisely because you got to remember, those words you'll never forget. When I lost my daughter, I never forgot the words said to me by the physicians when they talked to me those 2 times. Well, they talked to me numerous times, but the 2 particular times I'm talking about. Always show compassion to the families and crews. And remember, people may not remember your name, the great things you've done, but they will remember what you say and how you made them feel. You're selling yourself and selling your services to them. Even if everything goes wrong, if you sell yourself correctly, they'll have a positive response. Again, this has been Training on Acute Grief Life Support. Thank you for your time for watching this video today. And please remember, if you have any questions, please call us in the training office at 634-3013. That's 336-634-3013. Have a blessed day.